Good morning, dear participants. Good morning also to Father Ilo. And I'm very proud and delighted to be the moderator of this session, and welcome especially Father Stan Ilo from Chicago. And this is the fifth keynote speech of our conference. And Professor Ilo, he is from DePaul University, Chicago. He is research professor specialized in Ecclesiology, World Catholicism, and African Studies, working also in the Center for World Catholicism and Intercultural Theology. The topic of his presentation would be Health for the Poor, Ebola, COVID-19, and the challenges facing Catholic theological ethics. And let's give Father a big hand. We give the floor to him. Father, go ahead, please.
Thank you very much, and thank you for that generous introduction, and thank you, everyone. I regret my inability to be with you in person because this week we have Concilium Assembly. So I'm a member of the editorial board of Concilium, and I couldn't make it, but I hope that I'll be able to make it next time. Let me first commend the輔仁Academia Catholica International Conference organizers for this burgeoning partnership between Africa and Asia. We need more of this to continue to happen. It's so joyful to see so many African scholars, theologians participating here, and we hope that scholars from輔仁will return the favor when we invite you to Africa in 2025. My presentation is divided into three. In the first part, I'd like to look at Ebola and the devastating effects of Ebola, and then move there to ask the question, what are the things, what are the factors that contributed to the high fatality rate of Ebola when it occurred in Africa between 2013 and 2015 in 3 African countries. And then I make the case that if the world has learned the lesson from Ebola, the world would have prepared better to fight COVID-19. However, because it was considered an African problem when the epidemic occurred, because Africa was abandoned by the international community when the epidemic occurred, the lessons both in the resilience of Africans in fighting this terrible disease, the lessons learned, and the lessons learned about the commonality, what holds all of us together as one people. Those lessons could have helped when COVID pandemic occurred. Immediately when COVID pandemic occurred, when it started out in China, you could see a similar attitude about shutting down the airports, blocking people from coming out from China and from Asia, because that is what I will call in my presentation the control over care paradigm. So the goal was to control the disease. and control it in a very ineffective, insensitive, in an unethical manner, without people considering that we are all together. What happens here in Chicago affects everyone in the world. What happens in anywhere in Asia affects all of us. We are one family. And I conclude my presentation by making some suggestions about what we can do, what can Catholic theological ethics contribute in, one, addressing the wider determinants of health, social determinants as well as the commercial determinants of health. Secondly, in moving away from global health to what I call a social justice approach to health inequity. And then finally, what forms of partnership can exist among people from all over the world in order to promote conditions for cosmic and human flourishing. And I would say within the last 5 years, I have become very much interested in issues about health. And that interest led me to study global health. So with global health expertise that I gained through a master's in global health leadership, I focused my research on how the Catholic Church globally, so gathering some data from Philippines, some data from India, some data from the US, Canada, and some data from Uganda, Kenya, and Nigeria. How did the Catholic Church do during the COVID pandemic? So, what made us strong, and how can we get more of it? What is our community asset? And how did we bounce back? What is our community resilience that we can now leverage these in order to create a stronger church, a stronger communities that will be able to withstand the next pandemic? Because whether we like it or not, we're now facing the era of new pandemics, new infectious diseases. And sadly, for poor people throughout the world, many countries, many of them in my continent, Africa, have not made what we call the epidemiological transition. That means that for many people in Africa, they suffer the double jeopardy of being destroyed by infectious diseases and non-infectious diseases. So the epidemiological transition is one that shows that in many countries, many developed countries, what kills people today are diseases that emerge, like COVID, that people didn't have answers to. The non-infectious diseases like heart disease, diabetes, high blood pressure, these diseases are still killing people in many poor countries. People are developing, becoming diabetic early in life, and some of the therapies that could take care of their lives are not being provided. People are dying from high blood pressure that are preventable and treatable. Many women in many parts of poor countries are dying from childbirth. Under 5 years is increasing. And then infectious diseases that are manageable are still killing people. So we say that poor countries have not made the epidemiological transition. Now, my research so far has been to make a case for Catholic leadership, Catholic global health leadership, which is the topic of the book I'm working on, Health for the Poor. And some of the things I share with you, I have taken from my research about failing, how the world failed Africa during the Ebola pandemic, how the world failed the poor during the Ebola epidemic, how the world failed the poor during the COVID-19 pandemic, and what we can do about it. And in the first part, I want to base my presentation on the work of Paul Farmer. Paul Farmer was one of the co-founders of Partners in Health, and he published a book, Fever, Fuse, and Diamonds, Ebola and the Ravages of History. Paul Farmer died last year while working in Rwanda, where he helped establish a University of Global Health. He's been one of the most visible champions of a different kind of global health, not only working in the United States, but also in places like Haiti, in Botswana, in Rwanda, and also in countries in Latin America. And I got to know him when I took a course on lessons from Ebola, preventing the next pandemic. This course was developed by the Harvard Global Health Institute. It was run co-jointly then by Paul Farmer and the current COVID-19 White House coordinator, Ashish Jha. I participated in that course, and I was encouraged to then study more about Ebola and why humanity failed the continent of Africa. And then during the course of my research, I also looked at the work of the independent panel on global response to Ebola by Harvard Global Health Institute and the London School of Hygiene and Tropical Medicine. And 10 of the reforms they had recommended, none of which was implemented or applied during the COVID-19 pandemic. They have made these reforms, but again, the international community often is not concerned about what happens in Africa, sadly. And the poor always pay the price. And so I argue that if the world had implemented those 10 reforms of global health that would make it possible that once any human being is infected with an infectious disease in type A, the rest of the world becomes concerned. Not to run away from type A so that the person doesn't spread the disease, because we see that it doesn't work, it never worked during COVID. Shutdowns and shutting down the airport is the worst form of prevention. The way you prevent infectious disease, according to this reform, is to treat those who are sick. I mean, it's very logical, isn't it? That if people are sick in type A, rather than run away from them, cure them. And then the disease will not spread. Rather than say, okay, you guys are on your own, we better shut our airports so that no person comes from type A to any other part of the world. It does not work well. It didn't work in Ebola. The world was warned about it, and then they continued, and it didn't work during COVID. So the question that I want to consider this first part is, how did West Africa become a clinical desert? A place where rapid human-to-human spread of Ebola was not just possible, but almost inevitable. The answer, I argue, begins centuries ago, when pathogens and pathogenic forces were linked to a worldwide web of maritime commerce that bound expansionist European economies to the Americas and Africa. This terrible web began to take shape in the mid-15th century, when Portuguese explorers and traders gave Port Loko and indeed Sierra Leone and much of the Upper East their names. The result will be violent conflict, recurrent disease, and rapacious extraction of rubber latex, silver, minerals, gold, diamonds, and human chattel slavery. Now, how did Ebola come to Africa? Between 2013, when the outbreak of Ebola was first reported, and September 2015, more than 27,000 cases were reported, with 11,000 reported deaths. It was, according to experts, the worst Ebola outbreak in history, because in less than 6 months after the first case was reported, it had spread to 3 capitals of 3 African countries, Conakry, Monrovia, and Freetown. And I'd like to just remind all of you that the 2 countries that suffered most from Ebola, Sierra Leone and Liberia, were countries that were founded by liberated African slaves. Again, I make a case that the movement of people that began with the slave trade, the movement from Africa to Europe, to Latin America, to the Caribbean, to Asia, could not be separated from the way these pathogens have traveled, and some of these pathogens can remain latent for years. Now, in terms of the recorded number of affected persons, countries involved, and longest resistant transmission, the West African strain of the Ebola disease was the deadliest and most destructive, and the epicenter was Liberia and Sierra Leone. Since 1976, more than 25 known outbreaks of Ebola have occurred in Africa, and 5 different species have been identified. Again, you can see the relationship between Ebola. I mean, all of them belong to the same family, because just like COVID continues to mutate, the same way Ebola has continued to mutate into different variants, including the recent variant that started to spread last September in Uganda. Now, Ebola is a disease that is spread through contact with bodily fluids of symptomatic Ebola patients. It is highly contagious and kills more than 90% of those who are infected, particularly when they have no access to supportive care and therapies. The case fatality ranges from 41% to 89%, depending on the strain of Ebola virus and the setting of the patient. Now, without going into these different strains, I said that Ebola is highly contagious. But I like to correct that to say Ebola is highly contagious depending on where you live. If the Ebola virus had surfaced here in Chicago or in Boston, or like the SARS that surfaced in Toronto, there is little doubt that the healthcare system, despite shortcomings, could effectively contain and eliminate the disease with far lower case fatality rates than those reported now in West Africa, reported then in West Africa. So the question is, why the disparity when there is no proven drug or vaccine available? The answer to why Ebola kills so many in Africa is not with the virus, but in the collective failure of humanity. The failure to provide adequate care, staff, resources, and systems required for the delivery of high-quality health care. The Ebola epidemic placed into stark relief the failure or the destructive effects of what we call global health that I will come to shortly. It exposed the pathology of chronic neglect amid broad global inequities. I say chronic neglect because what we see happening with the health of the poor in West Africa, where Ebola devastated these three countries, is often the result of short-sighted local and global response to diseases like Ebola in Africa. It is also caused by reactionary measures to contain the infection rather than care for the sick. Because while we spend so much energy doing prevention, many people are dying. We should spend more money providing adequate, accessible, safe, and affordable care for the sick, and prioritizing health protection, not prevention. Health protection, that is, we must ask ourselves what makes people sick. What are the factors that provide the comorbidities that make the poor susceptible to diseases and deaths? Why can we prioritize access to high quality of life that improves the living conditions of people so that they are able to withstand some of these diseases, and when they fall sick, that they get the help they need, not only in very rich countries, but everywhere in the world, because the health of everyone should be the concern of all. You know, at the onset of the Ebola epidemic in Sierra Leone, many local doctors were working with resources similar to those that were used more than 100 years ago during the American Civil War. We must decry this kind of painful reality. The deserts, clinical deserts, public health deserts, and medical deserts among the poor that we found during the Ebola outbreak. So the question is, why? Why is it that Ebola killed so many people? And why did the international medical workers who came to Liberia and Sierra Leone to help, why is it that they didn't die from the disease? Many of them were flown out of West Africa when they became sick, and they got the kind of help they need or they needed, and that was what saved their lives. According to the World Health Organization, the lack of basic healthcare resources, such as PPEs, personal protective equipment, protective gloves and gowns, intravenous fluids, and straightforward protocols and guidelines, the limitation in the number of frontline health workers who risk their lives to take care of those affected, all these led to so many people dying from Ebola. Indeed, during the outbreak, many poor people could not even enter the few health facilities available. As a result, there was a high case fatality rate in isolated units of the hospital at the peak of this outbreak. Many healthcare workers died from the disease because of intra-hospital transmissions. Thus, during the transmission phase of the disease, many people lost trust in the healthcare delivery because people feared that if the doctors and nurses could not even shield themselves or care for themselves against this disease, then it would be unwise using the healthcare facilities under their watch. So Ebola was deadly because it occurred in Africa. If it occurred elsewhere, it would not be deadly. Because even before Ebola, there have been other, even more virulent diseases and epidemics, like the 1967 Marburg hemorrhagic fever, which occurred in Germany, the severe acute respiratory syndrome SARS, which occurred in Canada, as well as the Middle Eastern respiratory syndrome, the avian influenza, or the mad cow disease. None of them spread like Ebola. So we must ask ourselves, why did Ebola spread so fast? The same reason COVID spread so fast is the same reason Ebola spread so fast. But in the case of COVID, then it wasn't restricted to China, and then it started to spread elsewhere. Now, most public professionals know that the reason viral infections similar to Ebola that started to spread in other parts of the world before COVID-19 were contained was thanks to a mix of specific therapies, that is antibacterial, anti-parasitic, antifungal, and antiviral therapies. And then the non-specific therapies, the supportive and critical care you get in hospitals that have the staff, and the systems to provide quality care. That is what makes people survive. I mean, these are what makes people survive disease and infections like Ebola or COVID. The availability of these therapies outside Africa is the reason why American and European healthcare workers who were infected with Ebola and were flown back to the US or Europe survived the disease. They received the advanced care that many doctors in Sierra Leone, Liberia, and Guinea, even in Nigeria. One of the ladies who helped fight Ebola, one of the doctors who actually prevented this from spreading in my home country, died from the disease. All these medical care workers could have survived if they were provided with advanced care. So I argue that a comprehensive understanding of why Ebola and other related diseases, including COVID, kill so many people in the world invites us to the region, not of simply epidemiology, analysis of pathogens, but rather social medicine, that we have to locate the diseases within a complex history, politics, global neoliberal capitalism, and you name it. The reason Ebola killed so many of our people is not because they were blacks, not because of the food they eat, it's not because of the meat they eat, it's not because of the air they breathe, it's not because of their genes, it was simply because of their location. They found themselves living in this part of the world that have, over the last centuries, been treated as a land of desolation, misery, and suffering. And so I make a case, moving to the second part, that we need to understand why Africa is home to Ebola and why this infection persists in Africa. Because we just had an infection, as I said, last September in Uganda. So if we want to explain why this varying fatality rate among those infected with the same strain of virus, you have to understand the social context in which they live. The same is true of transmission of diseases. The setting determines what kind of care is available and how safely care is delivered. Similar points have been made regarding most communicable pathogens for well over a century. That century, the last 100 years, has taught us that medical impoverishment and high fatality rates and untraveled contagion can be radically and rapidly reduced by human countermeasures. So why are these countermeasures not taken in Africa during the Ebola epidemic? Why are these human countermeasures not taken during COVID? This invites us to look at the complex global history, and that's what I call colonial medicine, that we call today global health, which is a continuation of colonial medicine. First, we know that the economies of Africa have been ravaged by a different kind of epidemic. The epidemic of exploitation, the epidemic of corruption, by some very bad, terrible African leaders working in cahoots with their Western, quote-unquote, partners in crime. We know that Africa is such a rich continent. It is the home of humanity. Africa is made up of people, resources, rich. Many years ago, when Olaote Kwano, in the slave narrative he wrote about his early years in Igbo land, he said, in my homeland, that is before slavery, in 1781, Say my homeland in Ebola, in West Africa. There are two kinds of people you don't see. You don't see poor people, you don't see thieves. Why don't you see poor people? Because those who do not have, they are supported through solidarity by members of their own community. Why is it you don't have thieves? Because what belongs to you belongs to everyone. Communal life, relationships, social bonds. People care for each other. And so why would you go and steal something that you own? You cannot be stealing your own property. There was a flourishing of life. So what happened? Within the last 200-300 years, multi-packed us into what is going on there in Africa and in the rest of the world. Why some people decided to leave their own homeland and go into other people's land and devastate those places and impose on those places a framework that they think, because of white supremacy, that is the framework that should guide the whole world, with this false narrative of convergence of history, which is just a jaundiced reading of the diversity of humanity and then the imposition of these structures of neoliberal capitalism. So, I'd like to take you to colonial medicine, how colonial medicine caused the death that we witnessed during the Ebola outbreak, and perhaps, if we extend that analogy, how it helped to create the alchemy that led to the devastation of COVID-19. According to Quentin G. Ilo, and I quote, colonialism directly impacted medical practices and education in Africa by using medicine as a tool for domination and control. Medicine provided a biological rationale for assigning racial superiority or inferiority. Thus, medicine was used to rationalize and justify inequity and excesses under imperial domination. Unquote. The argument here is that we must consider slavery, colonial medicine, and its successor today, global health, racism, Western exploitation of the non-Western order as some of the major factors that quote-unquote manufacture epidemics and diseases in Africa and in the world. Our industrial policies, pollution, the kinds of things we produce today, the iniquitous air that we breathe. We must consider how these economies that Pope Francis says, how the economies that kill are actually contributing to the dissemination and spread of diseases and actually creating the kind of structures or systems of structural violence that make some people expendable as just part of this global chessboard of money, power, and exploitation. It is therefore important to go back to the colonial origins of Western medicine and the Western negative framing of African bodies, spaces, and context in order to capture the complexity of how they combine in manufacturing epidemics and death in Africa and in the world. Louis Pasteur, one of the leading men helping to develop the germ theory of disease, says, le microbe n'est rien, le terrain est tout. So, the microbe is really nothing. A disease is all about the setting, where you live. So we must look at embodied disparities, social and economic terrain. We must look at the attempt to desocialize and decontextualize epidemiology, as if to say this is just happened. This kind of decontextualized and desocialized medicine leads to a denial of history or the concatenation of factors that bring about the deadly politics that we have today, nationalism, for instance. or the narrow mentality that creates saviorism, protectionism, economic battles that are fought by the world powers that neglect social justice and the concern of protecting the environment. So I argue that understanding microbial pathogenicity in people requires understanding their context and history. So all those who died of COVID-19, like Aristotle said, when someone dies, he says, go and find out where he was born and how he or she lived. The setting is the problem. To understand why the deeper roots of global health inequity trace back through slavery, racism, colonialism in Africa, and why where one is born determines how the person will die, we need, I argue, a broader scope awareness of the diversities of stories from communities and people. During the outbreak of Ebola in West Africa, for instance, what happened was the priority was not given to providing care for the sick. It was all about, I call it control over care paradigm. Disease control rather than care of those who were sick. So people should die, some people were abandoned to die because no one wanted to touch them. Some people were abandoned to die because people were more concerned that they will be contaminated. And so they were left to die painful death without any form of therapy. This was a replication, I think, of tested method of allowing the sick to die during the colonial times. Example, the French colonial authorities responded to outbreaks. It was a policy. They responded to outbreaks of diseases during the colonial era, not with caring for the sick, rather with, I quote, the destruction of housing. Some people's houses were burned during colonial times because the people felt this house was contaminated, it has to be burned. Highly restrictive and segregationist building codes. Quarantine, from the Italian word for 40, which they say when people come to the coast, keep them on the coast. The whole idea was to isolate people. So during the colonial period, people who were sick were actually fined by the French if they stepped out of their house. They were rather confined in their home to die. What is the example among many others shows that there were no efforts to provide any care for the sick in Africa because their lives did not matter. What mattered was that the diseases felt to be congenial to African peoples and African environment, that it was contained in Africa. Now, as you know, in public health, people have started to give the name diseases after the place where it was found. Now, during the COVID outbreak, President Trump was constantly calling COVID-19 China virus. That tells you again this kind of wrong mentality of associating diseases with the setting without looking at all these wider determinants of health that we will now turn our minds to. Because I feel in this concluding part that we must look again at these factors and that Catholic global health ethics and Catholic social ethics should focus more on addressing the social justice approach to health more than the constant emphasis on the charity model of health, which is people are sick, find them health, send drugs to them, build hospitals for them. We must, as I learned from a Chinese friend of mine, he told me that in ancient times in China, if as a doctor, you are having more people, they will take away your license from you. Your duty as a doctor is to make sure that the patients don't fall sick. So maybe we need to, in Catholic theological ethics to concentrate more on health improvement rather than the quality of care people are given. That is also important. But let us not be focused mainly on prevention paradigm. We think about how we care for the sick, but also we think of how we stop them from falling sick. Because one of the discoveries we have in public health is a greater emphasis on population health to answer the question, what makes us sick? What makes us healthy? And how can we work on what makes us healthy so that we can reduce what makes us sick? I think that the most painful reality for me, considering the way Africans and African bodies have been trained in colonial medicine and today even in contemporary medicine, is how Africa is always presented in the literature as a repository of evil, of death, of disease and degeneration. And this leads to, is rooted on this called epistemology. But I like to go straight into what we call the social determinants of health. Because all these come together. When we look at the social determinants of health and then the commercial determinants of health, and then we can ask ourselves, how do we deal with these social determinants? My fellow rules here argues convincingly that the Catholic Church has been less engaged in public health than one would expect. However, the Church is very active in providing health care in most parts of the world, including Africa. For example, the Catholic Church has numerous health facilities in Africa. Democratic Republic of Congo, with more than 2,485 facilities, has the highest Catholic health facilities in Africa. Then it is followed by Kenya with over 1,000 health facilities, and my home country, Nigeria, with 524 health facilities. Now, why is it that the Catholic Church is not addressing the wider determinants of health and is more focusing on building hospitals and making sure that the sick are well taken care of? It's because that's what we inherited. Jesus did not go about searching out what was causing people to be sick. He just provided them with healing. Church, like Pope Francis said, is a faith hospital for the sick. And that's also in the literal sense, but also in a direct sense. The church lives to give life. However, in Africa, it is very important that we not only look at how to improve the church's healthcare facilities, especially in countries and in settings where they are non-existent in clinical deserts and hospital deserts and public health deserts. But we must pay more attention. I think the church is called to pay more attention to social justice issues. And that takes us into the world of the social determinants of health and the commercial determinants of health. So the social determinants of health are what we call social drivers of epidemics. The economic and social terrain that Louis Pasteur talked about. The therapeutic nihilism, particularly producing differential virulence, seen every day by those who work with the poor and see how the poor are exposed to diseases because of poverty, war, famine, natural disasters, and all kinds of other factors. In order to offer hope to the sick in Africa and anywhere in the world, and build effective health systems and provide optimal healthcare delivery in Africa and anywhere in the world, everywhere in the world, we must pay attention to those social determinants. Now, I use an analogy to explain what I'm talking about, social determinants. We talk about health. We use the analogy of a river. We depict illness as a river that people find themselves pushed into by adverse socio-economic conditions. They then flow down the river until, if they are lucky, the health service intervenes and pulls them out. The health service clearly performs a vital role in this case, But when we talk about social determinants, we think of the response that we have to do to say, what is pushing the people into the river? So rather than spending time trying to pull people from the water and because they are drowning, why don't we stop their being pushed into the river? So the social determinants are, in this analogy, all those things that push people into the river of sickness, that make them create comorbidities that lead to their death. The response of both the church and theologians in Africa and elsewhere in the face of the burden of diseases like Ebola, HIV, malaria, and COVID-19 has always been prevention, control, and maybe care. But I am arguing that we need to address hunger. We need to address bad government. We need to address neoliberal capitalism. We need to address dependency syndrome. And above all, we need to address what I call the commercial determinants of health. Because today, and this was a research done by some Asian public health specialists, today our world is inundated by food chains from highly industrial developed countries, food chains that are cheap food, that are filled with salt, sodium, sugar, and tobacco. These are things that are manufacturing death for so many people, especially the poor. Thirdly, while neoliberal capitalism and its associated false accounts of global convergence continues apace within the context of increasing public health issues in many parts of Africa, the accounts of health and well-being in Africa have been written by the WHO and other foreign agencies with a certain determinism, fixation on containing HIV, AIDS, and other random epidemics that reflect Africa's history, without paying attention to big pharmaceutical companies who are making millions and billions by producing vaccines, producing drugs. I mean, some people talk about toxic medicine, that is giving people medication for diseases that do not need those medications. I read a report recently that many CEO of healthcare outlets here in North America made millions during COVID. So people are making millions. The few are making millions from the death of the many. So according to the Lancet, one of the leading journals of medicine, health outcomes are determined by the influence of corporate activities on the social environment in which people live and work, namely the availability, cultural desirability, and prices of unhealthy products. The environment shapes the so-called lifestyle, and choices of individual consumers, ultimately determining taste. And I'd like to quote the director of the WHO, Dr. Tedros on this issue something out. He says, health does not begin in clinics or hospitals any more than justice begins in law courts or peace starts on the battlefield. Rather, health starts with the conditions in which we are born and raised, and in school, street, workplaces, home, water sources, teaching, and in the very air we breathe. What he is reminding us is that the many major risk factors for disease today and epidemics and injury are tobacco, alcohol, ultra-processed food with high amount of sodium and cancer-causing carcinogens, sugar-sweetened products, tobacco, and all the profit drivers that make millions or billions for so many people while killing people. Now, we have all these lobbies that people make for products. Even when we think of COVID, we think of how much fight over vaccines. Who's going to have the patent patent for the vaccine? And the logic of who should live and who should die. For instance, in places in Italy, there were times where the elderly were DNR. In places here in the United States, in Chicago, in New Jersey, a senior's home was found where all the seniors there died and no one cared. So DNR means do not resuscitate. So COVID, just like Ebola, has exposed for us that really the lives of the poor and the vulnerable are indeed expendable for economic and political reasons. Now, to conclude, because I want to keep within time, I have given my paper out. I want us to think, for one, about the quality of air we breathe in our cities, the quality of water we drink, the rich vegetations that we have that are often destroyed through urbanization and unregulated industrialization. We think of the crisis of waste disposal. We think of the kind of commercial interests that are driving even our relationship among humanity. The wars, all the destructive wars going on. And then think of what we can do as theologians, what we can do as people of faith in order to create a better possible world. And my argument is that the first thing that we must work to restructure is global health. Global health is simply the kind of health that the colonizing nations offer to those they colonized before. That's what global health is, a continuation of colonial medicine. So it is a way through which the Western nations describe the healthcare in other parts of the non-Western world. Because those of us who live here in Chicago, we're not talking about global health, or those of us from Africa will think of global health with regard to the United States. No, it is the U.S. that talks about global health. Or not for the health of the U.S., but rather the health of the rest of the world. So the standards and the policy are not the same. So we must work against a new understanding of global health. Second point is what I call the biosocial approach to health, which is built on social justice approach to health care, that looks at all the factors we've mentioned, that what makes people sick is not simply the germ or the pathogen. It is a whole conglomeration of factors. And so we should address these factors. That's why it's biosocial. Our common value, our common life must be protected. And that begins with paying attention to the most vulnerable in our midst. The poor, children, women, the elderly, those who are carrying some comorbidity. How do we take care of them? Human life should not be expendable. And that's what COVID-19 exposed to us, that some lives were considered expendable. And that's what Ebola exposed to us, that the lives of Africans were considered expendable by the international community. We are invited through this biosocial approach that looks at healthcare as our common good. It is one world, one people, one humanity, one earth. So I am happy and commend the organizers for focusing on this very important topic. I hope that what will come out from this conference will help us to advance Catholic social teaching and Catholic theological ethics from just talking about health and diseases and vision, health vision and all that, to actually facing squarely and courageously health improvement. That is the starting point, and health protection and health promotion. Now, health prevention is the last in that order. If you improve people's lives, then they'll be able to fight diseases. And that means improving their social condition, giving them jobs, helping them to overcome social injustice, working against discrimination, and working against all kinds of social policies that hold so many people down. I hope that we can all work together in creating the conditions for human and cosmic flourishing. Ultimately, that is what it means to be healthy, where everyone has life, and life in abundance. And I think theology, any theology that does not create that condition, that not reflect on how we can emerge, is a very deficient theology. But we need a theology that can bring down those who are hanging on the cross, those who are condemned to death, and raise those who are dead so that their memories can always be kept before us. So thank you very much for your attention.
Thank you, Professor Ilo, for your paper. I have read it before. I feel it's rich in content and with deep feeling, deep sympathy for the material and also questions raising. And your paper reminded me of there's a Canadian Catholic philosopher, Charles Taylor. He mentioned that modernity is characterized by four factors. The first one certainly is subjectivity, the second rationality, the third representation, and the fourth is domination. And I read in a paper how colonial medicine is a tool for domination, which is really shocking. I think shocking for me. I also read in a paper, besides the challenges, they also suggest the solutions. And I am especially impressed by the idea how to invest our influence on the world structure on medicine. And also the idea mentioned in your paper, how a faith-based organization, that's in other words the church or religions, how they can contribute something beautiful on this aspect. And on this occasion, you give me idea to read one of my professor in Leuven, American moral theologian Joseph Selling, my teacher. He has written a wonderful book, How to Reframing Catholic Theological Ethics, almost the same theme, Catholic Theological Ethics, how to reframe that. And on the front pages, I think page 3 or 4, he has mentioned a shocking idea. He mentioned the claim of Pope Leon XIII, on his encyclical Rerum Novarum, 1891. And in the encyclical, he mentioned that social inequality is founded upon natural law. Certainly, this kind of idea is transformed later by Parchenicalis of the Pope John XXIII. But I'm still worried about, since it's cited by Professor Selling, how it still exists among Christians. Such idea of social inequality is founded upon natural law. This point I'm reading because from what Father Ilo mentioned is something introspective, how to influence the outside world, the world medicine system. Me, as also a theologian of Bible studies, how to introspective to re-examine how among the church. I find that among the church our opinion is not unified. We are really diversified among our Christian community. How to readjust our positions and up to date and give a response, a powerful response to world medical system. And this is my humble reaction to Father Ilo's paper. Okay. Now we have still I think 5 minutes. Okay, 5 minutes, 10 minutes, 5 to 10 minutes. Let's open to the flow of discussion. Okay. Anyone participate? Please, Father, could you mention your name? Patrick. That's the first response. Okay, please go ahead.
Thank you. I'm Dr. Patrick from the University of Madras in Chennai, India. Dr. Shah, I appreciate your argument that this pandemic or response to pandemic should not be on charity basis, but on the basis of social justice, and we must evolve a global response to these kinds of pandemics occurring again and again. And the poor must be our target. That's a fine argument, very good argument, and it resonates well with the Catholic social ethics. I appreciate that. The question I want to pose it to you is, how prepared is the global humanity to identify the poor? You know, of course, poor out there in every situation, and we can take note of them, we can do charity to them, but in a systemic way to identify them. There must be a poverty index. Of course, UN has a poverty index, but every country does not adopt that poverty index. Say, for example, in the Indian context, they have their own. They tried to adapt that UN poverty scale, but it did not succeed. The multi-dimensional poverty index, which has come into force now, is also not accepted by several countries. So how do you kind of address this problematic of identifying the poor so that social justice could be, professionally implemented?
Thank you, Father Patrick. This question, I think, it is addressed to the speaker, Father Ilo.
Yes.
Do you have any idea to answer correctly?
Thank you, Father Patrick, Dr. Patrick. I think that it's a very interesting question, how to identify the poor. But I think that the greatest pain that I think, and the injustice we do to the poor, is to think that it is we who have to identify them. The poor, and I mean, again, I'm very conscious of homogenizing the word poor, but for lack of another word, I think that peoples everywhere want to become protagonists in their own history. They want to become agents. They don't want to be recipients of charity or recipients of goodwill. And for us, the task is to help to create those conditions that make it possible for everyone to have access to social mobility. And where it is not existing, to constantly raise the question, to pull down the structures of people, injustice and sin. Because the poor are there, and every human being, I think, is longing for health, for wholeness, for flourishing. And every community, and it's interesting, Pope Francis, what does Pope Francis tell us? You know, if we have to talk from the point of view of Catholic Ecclesiology today, I call it accountability. That means you have to go out. So the simple question is, how do you identify the poor? Then you have to go be with them. You have the smell of the sheep. That is the Pope Francis analogy. So we might not fall into the metrics nations about poor. It's about accompanying those who are condemned to die. And we see them all over in the slums, in the central periphery. We see them in jail. We see them women who are suffering in hospitals. So I think the simple way is actually to begin to develop theological ethics that is grounded in the experiences of people. We've said it so much. I mean, it's been said, the experience. But how do we know about this experience when even some of our churches and some of our theologies have become very removed from the daily experiences of people? So I think it's the answer given by Pope Francis that we have to step into the chaos of other people's lives. We have to have our boots on the ground, and many of us are doing it. And that way, you make the poor visible through the agency of your scholarship or your ministry and all that. That's what I would say. Let's become very very partners with the poor and allow them to tell us how. The poor are the solution to poverty because they know how to get out of poverty. But like one woman said to me when we went on a humanitarian work to northern Uganda, said, we're not looking for your handout. We want you to remove the obstacle before us. So how do you remove the barrier that make it impossible for the poor to break these chains? I think that's what we are all gathered here to reflect about in this conference. Thank you.
And now we open for more questions. Please, Father.
Yeah, Big Okwije, Duquesne University. Thank you, Father Stan, for that wonderful presentation. We come from the same country and we have always talked together. And I really understand the richness of your paper and the resources you propose. One thing that struck me during the last COVID-19 pandemic was that many African countries did not survive because of the money that came in. A lot of money came in. World Health Organization threw in a lot of money into Africa. In many African countries, the resources, the fund that came in, went into big hands. And I can't tell how many poor people saw the money and the resources. In fact, many people even they ran away from the vaccines. They did up to today they are not vaccinated, but they were not touched. But then there was something that worked. Local pharmacy. People who produced cure for COVID-19 pandemic in their countries themselves, including the Bishop of Douala, Bishop Kleda, monks in Nigeria. Different people produce even vaccines. Okay, but then the structure, the government structure, both international and national structures, refuse to publicly acknowledge those vaccines or those medications and support them. We saw what Madagascar suffered. Even the president of Madagascar came out and cried. They don't want, they produced a vaccine, and a cure, but they said they don't want to support us. So how can we now, talking about these global health issues, okay, help to support local structures? Because what Africa needs today is the support of their local structures. We are suffering from this dislocation, from destabilization of local initiatives that are very close to what people need. So what is your take about that?
Thank you.
Yeah.
Yes, please.
Thank you very much, my friend B. I think you make a very valid point. Shortly after the outbreak of COVID in 2020, the former president of Liberia, Ellen Sirleaf, wrote a letter to the world, and I think some of the things he said, she also said in that letter. What worked? Again, it's called community asset-based approach to health. So, or resilience, community resilience, how people bounce back. And the president was saying, you need to pay attention to Africans, what is working for them. Because again, when the international community all fled from Liberia, they had to survive. And so it is that survival skill, that strategy, when people were abandoned in West Africa, that he was saying, when people were pronouncing that COVID is going to, that they'll be picking dead bodies on the streets of Africa, it never happened because of these things that you mentioned. The people, there was also what we call the relational resilience. People were supporting each other. They didn't abandon people to die. People were supporting each other, so providing indigenous knowledge about sickness and diseases. If you like, some people say that Africans have become veterans at surviving diseases. So when COVID came, people thought the whole of Africa was wiped out. Then what happened? It was Africa that is the least affected in terms of number of fatalities. And it was in South Africa that they discovered the most dangerous strain of coronavirus. And when South Africans were talking about the Delta variant, they didn't even listen because they wouldn't believe that anything good come out of Africa. So the point is, global health is continuation of colonial medicine. Everyone who is critical in studying public health knows this. It is the way they want the people in Africa, in Asia to live their life. That is what you call global health. Because if you come down to Taipei, people are not talking about global health. Every health is local. And now the global intervention or health is, you can show solidarity. You're not going to stay in Washington and tell people in Taipei how to run their lives. I mean, you can gain knowledge. We live in an interlinked world. But where you create these structures that only what is Western and work, and then some people have assimilated this kind of mindset in places that you mentioned, Bill, and then they are not valorizing the agency of the people. They don't believe in themselves again. This is what you call learned helplessness. Somehow, after the devastating long history of being told that you cannot do it, that you are this, you are that, people begin then to accept this as a destiny. But then that's our role as scholars, to pull down these structures. And I hope that's what I've tried to do here, just to say that COVID or Ebola just didn't happen. And that it only kills people because of where they live and because of global health. And people start to talk about response to COVID the way they did. When it started in China, I remember in 2019 and early in 2020, people here in the United States were not even concerned. So if we can take knowledge from everywhere, medicine, people have always cured diseases, like Olau that was writing in the slave narrative. They didn't need any intervention from anybody to cure those diseases. But I'm not saying that we cannot learn from other sources, but we need to begin to respect local agency, local knowledge, and local practices, because unless you cannot push away people's culture in order to save them. That's not incarnational. So we have to find what works for the people and how you can get more of it, and that's what you're asking us to do. Thank you.
So thank you very much, Father Ilo. I think it's time's up for coffee break. So I once again thank you, Father from Ilo, Father Ilo from Chicago, and we wish someday we shall meet you in the campus. Okay, welcome you here in Taiwan. Now let's once again applause for Father Ilo and applause for